Good afternoon, everybody. How are we? Have we surviving this semester? Yes? Good. Is pediatrics as easy as you thought it was going to be? That was supposed to be funny. I know. It's late in the semester. You're tired. And we've got a long afternoon ahead of us. However, we have what I consider one of the most important lectures of the semester. The content today we're covering is all about mental health. And you're saying, oh, peds, mental health? There's nothing to do in mental health with pediatrics. Well, I would have to say that maybe 5 years ago, that might have been the case, but not, or at least not nearly as much as what I'm seeing now. But I can honestly say that about maybe, we're getting backlash. About 50% on a lot of days is either mental health related or has a mental health aspect that I need to be like on my toes for. Today was a prime example, and I'm not going to go into that. I have bored Dr. Blankenship with the stress of my morning already. So now, before we start, I'm going to show you a couple of things, wonderful resources that I think that are very important to me that I have learned to use. Do you mind bringing me Carlotte? So everybody's got to have continuing ed, right? Every year, and you've got to have so much farm, right? So, and if you're going to work in primary care at all, be it peds or adult or whatever, you're going to have people that come in with depression and anxiety, and you're going to be treating all that. And so part of what you can do is do psychopharm, basically CEUs. And this company right here, and Dr. Blankenship, this is what I use, but they also do this in an adult version, and they have several continuing ed things that you can do. It's like either 7.5 or 15 continuing ed units per one of their lessons. And so this company, there it is, Carlat Publishing. They are great. They've got several. I will use them again. I have to have so many for my pediatric mental health specialist certification. Also, if you're going to work in peds, this is also a very good book. It's put out by the American Academy of Pediatrics, Pediatric Psychopharm. I am working on a continuing ed right now, developmental and behavioral peds. So you wouldn't think that there's all this stuff out there that you would need. When I took my psych mental health, hold on, you can't see me, my pediatric mental health specialist certification, the Pediatric Nurse Association, this is the book that we use, A Practical Guide to Child and Adolescent Mental Health Screening, Early Intervention, and Health Promotion. It has a lot of the screening tools in it, a lot of definitions, and it is a very practical guide. It's not laid out like a regular textbook is. It's laid out more in lists. So good resources, very good resources. Here you go, friend. There's that. Okay, so we're going to start now. Chapter 15 is a wonderful chapter. Got a lot of information, very general information about assessing for mental health and mental health status. And that's a really, I just didn't have time with everything else that we're going to talk about today to spend time on that. So spend some time in some really in-depth reading on chapter 15. To get a good basis for what we're going to talk about today. I'm going to start out, and I don't remember if this is in 40, the neurological disorders. I can't remember if it's 40, 45. What were the other chapters? 15, 30, and 40 something, 46?
You're looking for the neurodevelopment, behavior, and mental health disorders.
Yes, that's the chapter. That's what we're going to discuss first. So so have that open, and we're going to go back and forth because in the old book it was laid out a little bit different. So I'm going to be like crisscrossing back and forth in that chapter. Okay, so we're going to start with the general, and you're going to pull this up for me, or do it? Let me see if I can do it, boss. Nope, that's not the one I want.
Hover right there.
Hover, this is what I want.
Is that the one you want?
Yes.
I told you the wrong one. Neurological disorders in children, sorry.
Can you all see that? Because when I pull it up, I can't see you.
I don't think we shared. Hold on just a second.
Yeah,
Are you
okay.
guys seeing it?
I need a thumbs up if you can see that. Okay. I know how to go to slideshow. It's just, this thing is so touchy.
It is.
I want to do my slideshow. It won't go. Ah, you do it at the bottom. She's got such a touchy computer. Okay, so this is where we're going to start today. All right, which chapter is that? 30 or 40, whatever. Somebody hold up their fingers and tell me numbers at least. Kylie, I've got you right there. Can you hold up whichever chapter we're on? 30? Okay, thank you. All right, so we're starting with chapter 30. So we talk about neurological development, and of course we know that neurological development begins at conception, because if you've ever looked at the fetus in the first 30 days, it looks like a little lizard. And so the brain and the spinal column are some of the first things to develop, and everything works from there. And there are so many things that can affect the neurological system, especially during gestation. And we all know that pollutants, drugs and substances, stress of the mother, trauma, genetics play a huge role, gene deletion, and we're going to talk more about that as we go along, and of course, birth trauma. So when we talk about just the basics, we talk about primitive reflexes, and we talked about this during development of the newborn. So there are your newborn primitive reflexes. And then you've got some later ones like the Landau. That's kind of like, I call it baby crunches, where they're laying on their back and they'll pull their head, their legs up. And then the parachute, of course, is when you've got Superman. I call them Superman, when they're laying on their belly and their arms and feet are up. So those are our primitive reflexes. So one of the first signs and symptoms or problems that you can see is, especially from neurological, and this can be from birth, and that's cerebral palsy. And that's the first thing we're going to talk about today. All right, we know that cerebral palsy actually encompasses a wide variety of really non-reversible disorders of movement and posture, and that originate in that developing brain. Now, it's really interesting that we have this class today, because this week I had a 4-year-old that I had seen in the last couple of weeks that had a history of having to have open heart surgery shortly after birth, and because of some cardiac anomalies. But all of a sudden, when I was doing her 4-year-old checkup the other day, her left hand was posturing, and she really wasn't using it. If she went to pick up something, she would use her right hand well, but then she would push up whatever against her left hand and pick up stuff like that. That was bigger. And I looked at Mom, I said, now she's got older brothers and she's a rough and tumble little girl, never had any other problems besides the cardiac thing. And she'd been on top of that. It's like, she hurt her hand? She said, well, no, but she says they play all the time. And she says, that's only been going on for a little while. It's like, okay, well, let's just x-ray it to make sure we haven't, hurt anything. Well, their x-ray was normal. And it was one of those gut kind of things that I decided, this isn't normal. So she also has a history of some juvenile idiopathic scoliosis. And she's involved with Norton's for follow-up with that. And so I referred her back to Norton's with this, because there's just something was telling me that something's wrong. There's something else going on. And Mom calls me very upset. Not that she wasn't upset with me. She was just overall upset because they looked at her and told her that her daughter of 4 has a mild case of cerebral palsy that had not come to fruition until now. So they're thinking now that the scoliosis is due to tight musculature on the left side, and that may be part of all that's going on. So she's in a whole new realm of therapy. Now, intellectually, it doesn't, of course, usually CP, it doesn't bother them mentally. It's more, unless it's pretty severe. Of course, right there, it says you can have disturbances in sensation and cognition and perception and communication and behavior, where hers is mostly musculoskeletal. So she may have other cognition and perception issues down the road. Communication is not going to be an issue. This girl will talk your legs off. But she does not have a history of epilepsy, but she does have the musculoskeletal issues. So it's going to be real interesting. So they're doing further testing and they're getting her into therapies pretty quickly. So mom's always been on top of it, but you kind of have to keep your eyes open. So cerebral palsy is not just something that is diagnosed at birth. It can manifest itself later in a child's life. So we have 3 different types. We've got spastic, which is muscle stiffening, causing muscle tightness, athenoid or dyskinetic, and that affects the muscles that enable smooth and coordinated movement and maintain the body posture. And then ataxic, which affects balance and coordination. And at this point, this young lady that I'm talking about probably has a little bit of the athetoid and maybe a little spastic, but otherwise, I'm not sure. The interesting part is that, like I said, at this point, it doesn't appear to be affecting her intellectually any. A lot of times we've seen CP kids that have quite a bit of involvement neurologically, especially musculoskeletal. They may be very spastic in their movements and uncoordinated, not be able to feed themselves because of the spastic movements. Speech may be an issue. So cerebral palsy can be very intense, and obviously it can be very minor. It is a non-progressive motor disorder, and it's caused by damage to areas of the brain that control motor function. So usually it's thought to be caused by birth trauma, however, not always, but the etiology is largely unknown. These are some of the next one is things that can contribute to cerebral palsy as far as other factors. Multiple births, being small for gestational age, prematurity, really puts them at greater risk. If you have a complicated delivery, as well as those others, and any intrauterine or during pregnancy drug exposure, of course, are torch, toxoplasmosis, rubella, cytomegalovirus, and herpes virus. All of those things can cause issues. Now, post-birth trauma, like meningitis, encephalitis, head trauma, falls, drowning, accidents, those are all other means of causing or developing cerebral palsy. So it'll be really interesting how they trace this back. I'm sure that our young girl with the former heart issue or with the heart issue is probably they're going to say that something because she was a preemie with a heart issue, that there was some trauma or at least lack of oxygen to the brain for a period of time there that caused it, but we're not sure. Some of the things that you're going to see, they may have cafe au lait spots or hyperpigmented areas, macules on the skin. We talked about the scoliosis and some contractures, and then DDH is developmentally dislocated or dysplastic hip dysplasia or dysplastic. Anyway, we used to call it congenital dislocated hip, but that's what DDH is. Neurologically, they may have some really hyper deep tendon reflexes. They may have increased tone, truncal tone, just very spastic, persistent primitive reflexes, or even delayed reflexes. They're going to have asymmetric movements. They're not going to be able to move the same on both sides or work hands together. Preferred handedness before 1 to 2 years of age, which is highly uncommon any other time. Head size may be either smaller than normal or larger than normal. A lot of the developmental milestones are going to be delayed. And depending on the involvement, the suck swallow may be involved. And a lot of times these kids will have really bad gag reflexes and have trouble swallowing and then aspirate a lot. When we talk about diagnostic studies, MRIs are not going to help a whole lot. Brain malformations are generally not present with cerebral palsy. The most probably helpful any diagnostic study might be either chromosomal array or karyotyping to see if we've got any missing gene deletions or known chromosomal defects. How are we going to manage this? You're going to refer any suspected cases of CP to a multidisciplinary center like Vanderbilt or Norton's, Cincinnati, Lexington, where they have pediatric specialists that are, and they're going to have to be seeing specialists in several different realms. Our job is to make sure we educate the family about the diagnosis and what's going on. Nutrition becomes a huge problem, especially if they have oral motor issues and they're very spastic and they have trouble swallowing, or even they're so spastic with their hands or with their mouth that they can't get food in their mouth or chew and swallow. Sometimes they will have special feeding devices and even special positionings that they use to help these kids eat. Sometimes these kids end up with a PEG tube or a external feeding tube, just so they can maintain proper nutrition. Elimination becomes a huge issue because these kids are so spastic, their muscles are so tight. Constipation is really common. They're at high risk for UTI because they can't seem to relax enough to allow the bladder to empty completely. So we have to stay on top of that. And a lot of the kids can't tell us if they're having pain. So again, if you've got a kid with a fever or confusion has increased, just like with our older adults, a UTI needs to be on your high rate of suspicion in these kids. Because of the spasticity and the malocclusion and the hyperfacial tone, oral hygiene as well as dentistry becomes a huge issue. These kids sometimes will clench their teeth and grind them off. There's always drooling. It's really, if you've ever been around them, your heart goes out to these kids that they just can't control it. And there's just something coming out of the corner of their mouth all the time. So respiratory with the spasticity and especially the scoliosis, respiratory compromise can be an issue because these kids, if they're non-ambulatory, just the pressure of wheelchairs, and you can imagine, would cause problems with skin breakdown. And then, of course, that's movement and mobility issues. They're going to be on maybe medications. There's really nothing that's going to control cerebral palsy, but some of the things that happen with it, like a hypertonic bladder and some other things, they may be on to help with that. Communication becomes an issue. I've had some of my CP kids have had to use special iPads to help them with communication and cards. Vision becomes an issue. Their bone become very brittle because of just the osteopenia from not being able to ambulate very well. And they're in a lot of pain with the muscle spasticity. So these kids really, really, my heart goes out to them. They're going to be in special education. I don't know if my sweet little 4-year-old she's not going to get any worse, but the tone in that left side, we're really going to have to work with. So it's going to be interesting down the road to help with her. So we're going to move from CP and we're going to move into now epilepsy and seizure disorder. Does anybody have any questions about CP at this point in time before I move on? Just, if you do, just pop in and ask. And if you don't want to take the time, then just send Dr. Blankenship a question and I'll answer it later. Okay. All right. So nobody has popped in. So moving on to epilepsy and seizure disorder. I'm sure that most of us either know somebody or has been around somebody who has a seizure disorder of some kind, either a tonic-clonic type of seizure or a focal type seizure or even absence seizures. So, and that over the years, in my 30 some odd years of being in nursing, it's been that long, 37 years. Oh my gosh. Okay. Anyway, so after the terminology and the categories have changed significantly as to how we categorize seizures, but just the definition, it is a misfiring of neurons of the brain, and it can be recurrent and it's unprovoked and not related to fever. And we're going to talk about that. Febrile seizures are a whole different topic. Okay. So those kinds of things are called epilepsy. So as we talked about, it can be focal or generalized. Sometimes they'll lose consciousness. Most of the time they can't remember anything from the onset of the seizure until they come out of it. Sometimes people will describe an aura. Sometimes they won't. Usually they will, what we call post-ictal sleep or confusion. They will, once the seizure is over, they usually sleep for a while or they're very confused. With a lot of our kids, I've got one particular autistic kid that when her seizures increase, mom knows that she's sick in some way, form, or fashion. She can't tell her any other way. And so she knows to bring her in. And also always usually with seizures, especially a tonic-clonic seizure, there will be incontinence involved because the body just loses that. Some of the underlying factors, of course, can be very specific medical conditions, previous infections, birth trauma, toxic exposure to drugs, stopping or withdrawing quickly from an anticonvulsive med. And you would be surprised, especially in our teenagers with seizure disorder, they get tired of taking meds and they just decide to stop one day. I'm not going to do it anymore. Recent head injuries are also a underlying factor, as well as family history. The interesting thing is, in the last couple of years, we've had a couple of kids that have started having seizure disorder with no known underlying factors, none whatsoever, just out of the blue. And it wasn't a febrile seizure. And over a period of a couple of years, then they didn't have any more and they're off their Keppra and no more seizures. So that's just really an interesting development in that. And you have to kind of decide between a true seizure versus a pseudo seizure. So some of the things that we see are focal weaknesses. So you may have weaknesses in the limbs, blood pressure may go up. You may have some, as we talked about, some systemic disease that might cause a seizure, like a strep or even flu or a meningitis. Cardiovascular disease. Now, it's probably not as much in children unless it's a child with some congenital cardiovascular issues. Now, your neurocutaneous diseases like cafe au lait spots and Ashley spots. You see a really good example here that the cafe au lait spots are the dark spots and the Ashley spots are the hypopigmented spots. And the little girl up in the corner, that kind of looks like port wine stain, but that's really a facial hemangioma. That's a big puppy. That's a big hemangioma. That's going to have intervention done and be involved. But those are some of our things that can be associated with seizure disorder. So what are we going to do? If we've got a kid that presents having seizure-like activity, these are some of the basic things that we're going to do. We're going to do a CBC. We're going to do electrolytes, including especially our glucose, because of course, hypoglycemia can cause seizure, or at least a pseudo seizure-like activity. And our urinary tract infection can cause it. Of course, we're going to do a serum tox. You're not going to do an LP, but in the workup, if everything else is good and you sent them on for further evaluation, they may do that either with neurology or in the ER, depending. EEG is going to be your standard diagnosis, as long as we want to make sure, check these other things, but an EEG is going to be your gold standard. So you want to set that up. MRI is not going to be done unless everything else has come back negative and we're still having issues. And they're going to do a CT only in cases of marked cognitive, motor, or neural dysfunction. Now, if the seizures are happening at night during sleep, they're going to do a sleep study. I send a lot of kids for sleep study, not because of seizure, but just because we seem to have this epidemic now of kids with snoring and having early issues, because we all know that can cause further down the road cardiac issues and hypertension and all the other wonderful stuff. So trying to be preventative at this age so that they can be healthier at an older age. So we're going to refer these guys immediately to a neurologist for diagnosis and initiation of treatment. Again, you may not do that initial workup and diagnosis, but you're going to be the one monitoring these kids with seizure disorder. If they need medicine, you're going to be the one providing the routine medicine levels and monitoring their drug levels and making sure that you're doing good case management on these kids. So it's really going to be really important that you know your common drugs and their side effects. So on page 992 in your book, table 4611, we're going to look, those are your most common drugs that we see for management for kids with seizure disorder or epilepsy. Valproic acid, carbazepine, levetiracetam, I think that's how I say that, but phenobarb, lamotrigine, topramate. We really don't use a whole lot of topramax. I don't see it. It's going to be more the others that we see a lot, especially the leva and the lamotrigine. So Lamictal and Keppra is a lot of what we see. We don't see as much phenobarb as we used to. And those poor kids when they were on phenobarb. I don't know if any of you all have ever seen kids on phenobarb, but it's just sad. So if they don't have to use phenobarb, they don't. So a lot of our kids will have rectal diazepam as a rescue, and parents are taught to use that. And if they have to, if a seizure goes longer than so many minutes, they're to use the rectal diazepam. I don't have any kids on intranasal midazolam, whatever that is, or buccal clonazepam. Most of the time it's a rectal diazepam that they're given for issues. So we've got long-term management. So after 2 years of seizure-free, they will attempt to withdraw the medication slowly after getting a baseline EEG at that point. So my little autistic girl, she's not little, she had been seizure-free for a while, and they thought they were gonna try to pull her off, and then she started having more seizures, and we had to make sure there wasn't anything organic going on. And so they're not going to be able to withdraw her. But yet another child, a couple of children that started having seizures when they were in their first couple of years with no known etiology, had been seizure free for a while. They did the baseline EEG and started pulling them off their meds, and are now they're seizure free and they're off their seizure meds, and never could explain as to why they started having seizures. So withdrawal over these meds occurs over a span of months. Both your book talks about this, and so does some of the other literature that I read and work with. The ketogenic diet seems to be very useful in children with all types of seizure disorder. Ketogenic diets are really hard, especially in kids, because a lot of times they're so picky. You have to be tight control to really to produce the right type of ketosis for this to be helpful. So they're saying that your ages 2 to 5 are the best because they're most compliant. So good luck with that. I haven't worked with that yet, and I haven't seen any of our neurologists recommend or prescribe a ketogenic diet for our epilepsy patients. Sometimes the seizures are so bad that they have to go in and they either have to sever or ablaze a nerve so that they can stop certain types of seizures. There is concern for administration of the diphtheria, tetanus, and whooping cough or pertussis vaccine. The CDC in your book states that they do recommend deferral until the neurostatus is known and you've got approval by a neurologist. I think that's just good medicine. If you've got a kid that's doing that, you can always give that DTP whenever, but make sure that the neurologist has given the okay. We all know what status epilepticus is. That is a continuous or frequent seizure without any recovery. And that can be very hard on a child. It's hard anyway, but when there's no recovery period, it's hard on the parent, especially if they're using diazepam and they've used all their diazepam. I had a child recently with febrile seizures that went for 45 minutes without any really relief. So mom was absolute basket case by the time I got to talking to her. It happened at night. And so they were at the ER, and then they were in Louisville for 2 days. And that's exactly what we're going into to talk about now. It's febrile seizures. This is the most common type of seizure in children. They're very brief and generalized. They're very tonic-clonic in nature. And it usually is concurrent with an illness with a fever. Now, it's usually not related to how high the temperature is. And that's what freaks parents out. They think if it's that 103 that they're getting ready to go into a seizure. It's like, no. So it's our job to educate parents that it's not how high the temperature is as much as it is how quickly it goes up or how quickly it comes down. So we have to educate them as far as bringing temperature down. We want to bring temperature down slowly. So you don't want to stick them in an ice bath, and you don't want to stick cold cloths on them. You want to stick them in a tepid bath if it gets really high, if your antipyretics are not helping. You want to wipe them down with either warm cloths or lukewarm cloths, and maybe just pull their clothes off. We want to do this slowly, okay? But once a child has had a febrile seizure, parents are absolutely, and if any of y'all have children with febrile seizures, then speak up, because the parents that I've had experience with, they are just petrified and paranoid of any fever whatsoever because they're scared to death of having a seizure again. We really don't know what causes it. It's more common in those with a family history, or if they've been in the NICU for a while, or if there's some other kind of underlying factor like a developmental delay, or even those kids who are in daycare. The most common age range is from 6 to 60 months. It's more common in males. I've seen it in both. What are they going to do at the ER? They're going to do a lumbar puncture if they're younger than 12 months. They're going to check all the electrolytes, especially glucose and calcium, a CBC, EEG. Remember, that's our gold standard. And they're going to do our MRI if it's indicated. Usually they're not on long-term prophylaxis. It's all about making sure that they manage the fever. Antipyretics are our best defense. And we talked about it's when it's going up or when it's falling, go figure. We can't always predict that. We talked about the rectal diastat in case, and usually there are no long-term complications from febrile seizures. And the younger the age, the less the temperature threshold needed for a repeat seizure. And so our younger kids are more prone to having frequent febrile seizures. And of course, those are kids that really can't talk to you a whole lot. So that's even more terrifying for a parent. Okay, any questions about seizure disorder and febrile seizures? All right, so we're going to kind of switch gears just a little bit. We're going to talk about brachial palsy. Now, this is a stretch of that brachial plexus, and that just usually happens during a very difficult vaginal delivery, and to be honest with you, even some C-sections. One of my favorite shows right now is called The Midwife. So they have some really interesting stuff on there, and I'm trying to see if I can beat them at the diagnosis. But when they were talking about that, sometimes there's an elbow presentation or a shoulder presentation, and some of the things that they have to do to get some of these babies delivered. These are some of those situations in a hard delivery, or where the baby is not presenting correctly, or it's a really big baby, is when you might see a brachial palsy happen. What happens is the upper cervical nerve roots of C5 and C6 get that stretched area. Sometimes it's called Duchenne's palsy or Erb's palsy. Now, when you get the lower ones, C7 and 8 or T1, it's called a Klumpke palsy. And that's different. That's where everything but the hand is normally functioning, but the hand won't function at all. I think that is correct. If that is not correct, somebody needs to tell me. And I don't mind being corrected if I am wrong. So this can be very mild to very serious, even involving the diaphragm, especially if it's up at C3 to 5, because that involves our breathing areas. I have seen kids, I've got, she's kind of like a niece, her daughter had brachial palsy, and she doesn't have, excuse me, any complication, thank you, from it. And then I have another friend whose grandchild was born and had significant issues to the point there was lots of physical therapy and still has some issues. And the child's like pushing 10 years old. So I never thought that usually it all worked itself out, had been my experience. That was the first one I knew that it had multiple complications or further complications than just at birth. As we talked about, shoulder dystocia, high birth weight, lengthy labor, breech delivery, of course, especially when you got an arm that doesn't get delivered before the head gets delivered before the arm does. So it's a really interesting delivery. Also, maternal gestational diabetes, which usually means a big baby. Forceps or vacuum extraction can also cause that. And then also kids who are in car accidents, restrained with the seatbelt, you can see a secondary brachial palsy. That's not related to birth trauma. So most of the time it's very visible after birth. There will be asymmetrical movement of the arms. With herbs, you're going to see the internal rotation and adduction. Okay, adduction rolls in with the wrist flexion like a waiter's tip. So the hand is up and rolled in. The clumsy is a paralyzed hand and forearm with good shoulder and elbow function. I had it mostly right. Total plexus avulsion, you've got a completely flaccid upper extremity. That means that brachial plexus has been stretched so tight that it's avulsed, it's pulled apart. And then Moro reflex. Moro is that when you're lowering a child and the arms go up, is a really good indicator of symmetrical movements of the arms, because both arms will both go out when you're doing that. And if that doesn't happen, then you might be concerned. You're going to send these babies to PT for range of motion exercises by the parents, and to ortho-neuro to see if any nerve grafting or, make sure that the nerve involvement is limited. Okay. So most of the time that works out, again, on its own, but it needs to be identified. It needs to be treated. Headaches. All right. So turn to page 978 in your book and just start highlighting some stuff. Box 46.2 is significant. And that's where we're going to kind of start. Headaches are an open-ended diagnostic nightmare. And if you heard me talk about that with belly pain, then this is the same. So when you've got a kid comes in with a headache, it could be minimal, or it could be, like I said, a diagnostic nightmare, because, and it's a very common reason for an office visit. We see it all the time, but it can range from what you're talking about. So, and most of the time, these parents, if these headaches have gone on for very long, parents are really afraid of the worst case scenario. They're afraid that they've got a brain tumor. A lot of times, a common part of childhood that increase with frequency and intensity into adolescence, and they can be acute, they can be chronic. We have got different types. We've got migraine headaches, infrequent tension type, and chronic tension type. So that's discussed well in the chapter. Migraines, you'd be surprised how many kids have issues with migraines that we really don't think about. We think about adults having migraines, but when you've got a kid that comes in and says, my head hurts so bad that I have to go into my room and lay down and have to turn all the lights off, and I take a couple of Tylenol or I take a couple of ibuprofen, and in a couple of hours, I feel better. That's really classic migraine. This can be hormone related. It can be genetic related. A lot of times these kids have a family history of other members of the family have history of migraines. Of course, we have to do a full workup. We have to rule out all the nasty stuff, but most of the time there's a good reason for it. The infrequent tension type, most of us have that. Probably you all will have that by the time we get done today. After listening to me for almost 3 hours, you will have a infrequent tension type headache, or after you've read for a while, or after you've taken a test this semester. or before the test. Maybe the tension goes away afterward. But that's really common. And then chronic tension headaches are usually in the back of the head and the neck. And they're there fairly frequently. So when we start talking about the very first thing, the most important thing that we can do is to do a very good history. So one of the things we're going to ask our families to do is they're going to keep a headache journal regarding how frequently the headaches occur, what's going on at the same times. Are there any foods that we ate around this time? What activity you were doing? What time of day was it? We want them to journal about, and we want them to do it for at least a month. The duration, we want to know if it's a recent severe onset. If it is, it's concerning that our little antennas need to go up if it's a recent severe onset. So some of our frequency and triggers, especially with girls, is their menstrual cycle. Exercise can also be certain odors, certain foods, chocolate, aged cheeses, caffeine. Does anybody see any pattern there with other kinds of things going on? Nuts, processed meats, dairy, shellfish. So we've got some kind of an allergy component that triggers a headache. Where is the headache? Is it in the front? Is it on the side? Is it in the face? Is it in the back of the head? Is it sharp, throbbing, pounding? All those wonderful things. Usually migraines are dull and constant. Dull, and tension type are just constant. How old were they when headaches started? Has they gotten worse over time? What are the things that you're doing at home? Anything else go along with them? Do we get sick to our stomach? Do we get nauseated? Are we having any visual changes? Do we get dizziness? Do we have ear pain or belly pain? Because some of our migraines can be abdominal migraines, and it can cause abdominal pain. Are we having any personality changes? So there's just lots of things that we need to know. Is there any history of head trauma? Are we having school stressors or any issues with our family? Are we depressed? We talked about family history. There's migraine with aura and migraine without, and that's on table 46.3 in this chapter. Read over that. We talked about it, abdominal migraines. Usually it's in the midline. We have some nausea, vomiting, maybe, and it comes and goes. It's really interesting though. A lot of times we'll get this, oh, I have a headache every afternoon. Oh, really? The most common cause for headache pain in a school-age child is dehydration. Even mild dehydration can cause headache, especially in the early afternoon. So if they seem to be having a headache when they get off the bus or get home from school, push a glass of water, wait for 30 minutes and see if the headache persists. Because, well, this year it's been a little bit different because most of the time kids aren't allowed water bottles and things like that at school, and they have to go to the water fountain. And if you all remember what it was like, you got maybe 10 seconds. The teacher would stand at the water fountain, everybody would be lined up, and you got a count of like 10. And then the next person go. And then you got liquids at lunchtime, and you got an afternoon water fountain break. And that was it. Most of us drink more than that. So we need to make sure our kids are well hydrated. So with box 46.3 in your chapter, these are some of the red flags that we need to be worried about when we talk about headache pain or headaches with children. This is like the first one listed is our number one, is the headache pain is worse in the morning on waking, or actually wakes them up and standing up and then fades. If they have a headache when they wake up and they get up and it goes away, that's not a good sign. If it increases in intensity and severity over a short period of time, or if it's just on one side of the head, those are significant things. If it wakens the child from sleep, if we're vomiting but we're not sick to our stomach, we have visual disturbances, and so on and so on. I'm not going to insult your intelligence by reading the rest of it for you. So down there at the bottom, it does talk about history of VP shunts, hydrocephaly, meningitis, or tumor. If we have any of those, that actually should probably be pushed up to the top, because I've actually had a child whose VP shunt dysfunctioned or malfunctioned, and it caused significant headaches, significant issues, lethargy, almost to the point of becoming unconscious. And the pain was just excruciating for her. So when we talk about headaches in infants, which is box 46.4, some of the, and these are not necessarily for headache, but reasons, causes of increased intracranial pressure. So if you've got an anterior fontanelle that's bulging, you need to be concerned. That is a huge red flag. We had a recent issue where the mom brought this kid in just crying and crying and crying. It was, I don't know, a couple of months old, just crying all the time. We thought it was formula related, GI related. The baby was vomiting, and then all of a sudden it shows up one day and part of this issue. And the doctor I work with looks at this baby and touches his head, and it's got this huge bulging anterior fontanelle. And this baby had brain bleed from being abused. So you've got to look at those things. If we're having poor growth, if they can't look upward, so you got to be checking the gaze. These babies, you've got to check, up, down. Will they follow the light? Will they follow you? You're looking at head growth patterns. That's where those curves are very important. Babies with increased intracranial pressure has the most piercing, shrill cry that you've ever heard. Also, these babies have a tendency to be floppy. They are lethargic or they're vomiting. There is something really going on with these babies, and they need immediate intervention. So this article, did you remember that I sent you this? Were you able to pull it up?
I apologize, I don't remember.
Okay. This article, I tried to do this at home and it wouldn't come up. I don't know if it'll pull up. It says identified a security concern.
Yes, though. Let's see what happens.
Okay. What is that? What did I do? Well, I will click on, and nothing now. Let me click on the article. It says hyperlinks can be harmful to your computer, blah, blah, blah. It's not going to do it.
Okay.
If you will let you, if you can find this is a great article for treatment of pediatric headaches. I'm sorry, like I said, at home, but I have sucky internet at my house. I couldn't pull it back up. But try to pull that up, and Dr. Blankenship will make an effort to find that and see if we can get it posted if we can't pull it up.
I'll get it posted.
Okay. So what are we going to do? Most of the time, we're going to give them NSAIDs. If they can take it, we're going to give them ibuprofen. And if they're over 6 months of age, we're going to do somewhere between 7.5 to 10 milligrams per kilo per dose. And that can be done every 6 hours. And then that's the Tylenol dosage. I had a kid this week that was having headache, actually other inflammatory issues, and we were going to put him on ibuprofen, but the patient's also on sertraline. So the two of them together do not work well because it can cause a GI bleed. But it's one of those things you have to know and pay attention to your what you would call it when they come up, your warnings. Yeah. Yep. So acetaminophen is available. Naproxen also, but they got to be older than 2. And those are your dosages. Adolescents, you can start them at 400 milligrams. But this is how we're going to start. And if that's not working, there we go. If that's not working, some of the things, and this is on table 46.6, it goes through a list of different things. So we got antidepressants, that category. So Elavil or amitriptyline, we use it a lot as prevention. And that's the dosage and how you increase it. Most of, depending on the size of the kid, of course, usually about 25 milligrams, some maybe 50. I'll use a lot of ciprofloxacin or periactin. It is a appetite stimulator, and it's also an antihistamine. I use it a lot in younger children. Now, the interesting part is I've also used a lot of propranolol or Inderal. And I usually use this in older children, and you have to be really careful You can't use it in kids with asthma, and you have to be really careful about those with depression. That's where your Elavil kind of comes in. Because of, and you've got to watch the blood pressure. So, and you need to tell them that this can cause their blood pressure to go down, and it may feel them weak or dizzy at times. So that's where pushing fluids is really important. Anticonvulsants, Topamax has been used a lot, especially in the past. I don't use Topamax. If a neurologist wants to use Topamax, that's great. But we try to do the best. We should be starting with amitriptyline and moving down this list. The book may say something different, but trust me, this is the list that you kind of need to work through. Like I said, older kids, I'm going to do the propranolol over the cyproheptadine. Especially my heavier kids, I'm not going to do an appetite stimulator because that's the last thing that they need. And then I'm not going to do a blood pressure pill in my babies. So, questions about headaches? Okay. The next topic we're going to talk about is traumatic brain injury and concussion. So that's been in the news a lot, especially with our professional athletes and our high school athletes. As family nurse practitioners working out in the community, they're going to end up doing a lot of return to play. Now, the KHSAA has a return to play form that's on their website after post-concussion. So you need to look at that. You need to be familiar with it. So you are going to rarely do an initial assessment for traumatic brain injury. Most of the time, even if they call and say, hey, my kid's fallen, it really needs to be done in the ED because they have the right equipment right there to do any imaging or immediate attention to any problems. And they can get, if a CT needs to be done, they can get it approved, and it might take hours in the office to get that done. So if you're concerned about concussion and traumatic brain injury, that usually needs to be done at the ED. So you need to know what the signs are. You've got cognitive, physical, emotional, and sleep issues, and that's on table 46.9. And those are your concussion symptoms. Now, table 4610, there's a head injury acuity risk assessment that you need to be familiar with. And your book says all children with moderate, which is Glasgow Coma Scale 9 to 12, and severe, which is GCS 3 to 8, acute head trauma, should have a cranial CT scan. Very controversial in peds as to everybody, the kid had a head injury, everybody got a CT. Well, that can be really damaging to young brains. So they have developed this acuity. So with the Glasgow Coma Scale, but there's also a Glasgow Coma Scale for pediatrics, and that's also in your book. And these are some of the signs and symptoms that warrant a CT besides just your GCS scales. If they've got any depressed skull area, you might want to do a CT. Any altered levels of consciousness, amnesia, they can't remember anything. If they're having some of those neurodeficits, if they are having vomiting, any seizure-like activity, or if they've got a history of some clotting issues. I had a personal experience with this with one of my children. Could not, when he was little, he's 28 now, haven't figured out how he actually lived to be 28. He would do backflips from the coffee table to the couch. I couldn't stop him, no matter how I disciplined him. And one day I was in the basement, and all I heard this boom. And then about 2 seconds later, another boom. And then a period of 2 or 3 seconds. And then this wall just scream. I thought, oh no. Well, he had missed the couch, didn't get all the way over, and fell back and caught the back of his head against the coffee table and then the floor. So he was crying really hard. He didn't lose consciousness, but later on, I called the doctor, said, what do we need? She said, well, come on in. Let's just check him. We don't, we may or may not do a CT. And I said, okay. Well, as soon as we got there, walked in the exam room, he started throwing up clear liquid. And she said, she looked at him and she sent him for a CT, and it was normal. And so she sent us home with some nausea medicine. That was before Zofran. And he continued to just lay around and lay on my lap, which was so unlike him, and just kind of in and out and whine, and just like he couldn't get comfortable, and he would roll over and throw up, and then he'd roll back over and roll over and throw up every like half an hour. And after about 4 or 5 hours, I said, and how long before we quit throwing up? And she said, pack your bags and come back. You're going to be admitted. And he continued, we were admitted, started an IV, and we continued to he just kind of continued to be in and out until about 9 or 10 o'clock that night. And he looked over and said, hi, Mom. It's like, well, hello. It's like, he said, what are we doing here? Where are we at? What are we doing here? So evidently he got a really good whack to the head that caused a concussion, although he never lost consciousness. So be wary of any head injuries. There may be delayed bleeds. There may be delayed issues. So even if the head injury happened 1 to 2 days ago, if all of a sudden you're starting to see symptoms, it could just be from a delayed response. So don't rule that out. That's where your histories are so important. So as it says, there's our concussion symptoms, and this is all on table 46.9. If you've ever seen it, you won't forget it. But that's really important. So again, get familiar with that return to play on the KHSAA. As providers, you're going to be needing to fill that out and to do that. So concussion happens. We want to minimize the amount of trauma to the brain as much as we can. So we're going to promote what? We're going to promote helmets when they're on bicycles, seat belts when they're in vehicles. Anytime they're on any kind of motorized vehicle that they're not enclosed in, they need some kind of a helmet on to protect their head. So we move from traumatic brain injuries to head shape issues. Now, this is some might blow this off, but these are some pretty significant issues. Macrocephaly just means a big head, greater than 2 standard deviations above the mean for age and gender, or 1 increases in size too rapidly. We measure heads at every well-child checkup. We're OCD, you come around the head, you come right above the ears and right above the eyebrows. And the tape needs to be tight against the head, kind of like if you're measuring your waist for your waist circumference. You want that tight around there. So you measure it accurately. It does not need to be loose. And because if a baby has hydrocephalus, or if we've got an issue with a traumatic brain injury, if we've got any open fontanelles, if anything's going on, if this head is all of a sudden has jumped 2 or 3 standard deviations from the last time they were here, do we have something else going on with this baby? Do we have a tumor going on? Is there any other neuroscience that we should be looking at? So macrocephaly means big head. And I got a lot of babies with big head, but they're on a consistent curve. And they're growing along the curve. And I'll look at the parents and say, okay, who's got the big head in the family? And they'll usually point to one or the other, or say, oh, my family size just got really big heads. And it's like, okay. Microcephaly means really small head, and that's 2 standard deviations below the mean for age and gender, or a decrease in normal growth pattern. So if we've got a baby's head who's growing along and then all of a sudden it's not growing anymore, and as they get older, that just means that it drops across the percentiles. Does this baby have an open fontanelle? Do we see any neurological signs? And we're going to talk about one of those reasons that could be. A couple of years ago, and it's in your book, and it wasn't in the 6th edition, but it's in this edition, and that's Zika virus. We know that Zika virus has been identified as causing microcephaly if caught during a particular trimester of pregnancy, and can cause a small head, which can cause all kinds of neurological problems down the road. So small heads have got to be evaluated. Is the head in proportion to the body size? Is our length and our head circumference in proportion? So you can have a small body and a small, then you would say small head would be normal, okay? So you got to look at those kinds of things. Hydrocephalus, as we know, is an abnormal collection of fluid in the dural layer of the brain and can either be congenital or acquired. So you need to look at box 46.4, read through that, and that can cause, of course, when we collect all that fluid and it's not going anywhere, it's going to cause an increase in head size and circumference of the head. Now, craniosynostosis is usually a skull malformation due to a primary or a secondary cause. When I think of craniosynostosis, I think of premature closure of the fontanelles or overriding sutures that aren't opening up, because a lot of times these babies will have overriding sutures if they had a really difficult delivery through a very tiny pelvis. And that's the one wonderful thing about the brain is those 8 bones in the head can move as that head comes through the birth canal. So if you give it a little time and that doesn't open up and separate, if they've got a ridge right here or a ridge down the middle that looks like it's overlapping, that's significant. You need to watch for that. And if we talk about the premature closure, it is the sagittal suture, the one that goes right down the middle. Now, they're also listing what I call plagiocephaly as a type of craniosynostosis. Now, in my 15 years of practice, I've only had one, maybe 2, and this was while I was in Eastern Kentucky, that actually I referred to pediatric plastics for reconstruction and opening of the skull because it had closed early and was causing problems. So I haven't had any of that here. Maybe, no, I haven't had any of that here. But plagiocephaly is acquired, basically. It's positional. How many of you, and some of you are parents, but we all know that the perfect position for a baby to sleep because of to decrease the risk of SIDS is to lay it on its what? Its belly or its back. We will lay it on its back, right? Back to sleep. But in doing that, we don't always keep the head turned or move the head around. We lay them on their back and on the back of their head. Well, all those bones are just so easily moldable. What happens? We get a flat, we call them the flat heads. And that has been the unfortunate consequence of back to sleep has been all these flat back heads. Or they like to lay on one side. They lay in a crib and they look at their parents and they lay them the same direction every night. So they lay on one particular side and we'll either have a flat side on the right or a flat side on the left. Very seldom do we have flattening of the front area. It's usually one side of the back or the other or way back here. The interesting part is that helmeting is very helpful. We have a great locally. We have access to a wonderful assessment center that can put these kids in helmets. A lot of times, all you've got to do is let parents know. It's like, okay, this head needs some shaping, or it's gonna close and be flat forever. And so you start talking about making sure that we turn the head from side to side, or we get maybe a little baby neck pillow so that so it doesn't necessarily turn all the way one direction or the other. And we get some reshaping of the head. Most of the time it can be done at home. For the other severe cases, some more severe cases, we usually end up sending them to, don't ask me what the place is, but I've got all the stuff. But anyway, they do the evaluation and they put it all in the computer and they design a helmet that's going to help this baby get their head back to normal size. Any questions about head sizes? Okay, moving on. All right, spinal cord issues. This is huge. I could spend this whole time talking about spinal cord issues, but some of the things that we're going to talk about are tethered cord, and spina bifida and myelomeningocele. Now, tethered cord, usually the caudal or the end is free. But with a tethered cord, there's like a little rope-like filament at the end of T12 that is attached, kind of like a string that just, hello. Now that can cause abnormal stretching or damage to nerve cells. It can cause blood vessel issues. Eventually, it just causes neurological deterioration. And like I said, most of the time we identify a tethered cord with spina bifida, but it can also be caused by several other things. So what might you see? You may see some asymmetry of foot or length. You may see some muscle wasting in the infant, like in their leg weakness. Incontinence of bowel and bladder is significant. If you've got a kid that maybe has some gait issues, but they are older and they can't seem to, parents are frustrated because this kid will not potty train, but when he runs, he falls down all the time. Well, that should be a red flag that we need to be looking, at something else. These kids with scoliosis, if they've got any deformities of their legs, thighs, thigh folds, we need to be checking and making sure they don't have a tethered cord. It doesn't always show up at birth. Some of the other manifestations you're going to see, they may have dimples above the gluteal cleft or right at the edge of the cleft, or in some hair tufts. The gluteal fold may be deviated just a little bit. You actually might have a fat pocket along that, or some birthmarks right there midline. If you've ever seen a baby with not just a dimple, but with it looks like a hole, like a sinus tract, and if you can't see to the bottom of it, those things need to be evaluated. Those are really good indicators that there may be a tethered cord. The Arnold I can't say that today. Chiari 2 malformations. Okay, Chiari. That sounds about right. Okay, so it's an uncommon congenital spinal anomaly that usually isn't found until late childhood or into adulthood. I have a lady that I taught with that didn't find out she had a Chiari 2 malformation until she was in her 30s. The type 1 malformation involves downward herniation of the caudal end of the cerebrum vermis through the foramen magnum. So they get headache, neck pain, atrophy, decreased reflexes in the lower extremities. They may be weak in their legs. They may have some sensory losses and scoliosis. Now, the type 2 has the herniation, but also alteration in the shape and development of the medulla. So you're going to see some of that, but you're also going to see some maybe hydrocephaly, respiratory distress, maybe some syncope, poor feeding, vomiting. So if you've got these babies that have some of these issues, then you might need to think about a spinal cord issue. So any child who has myelomeningocele, and myelomeningocele is a child who is born with an opening that with the outpouching of at least the meninges and a part of the spinal column exposed on the back, and they should be suspected of having a type 2 malformation. And we are never going to do an LP in a kid who has a type 2 Chiari malformation. Management of these can be surgery, or it can just be managing the symptoms and doing appropriate therapies. But anytime I've got one myelomeningocele patient that I'm working with now and have been since birth, and he has a Chiari 2. So we just talked about myelomeningocele, and it's that failure during embryogenesis of the vertebrae, the skull, the meninges, brain, spinal cord to be encapsulated. Okay. Why does this happen? It's thought to be related to folate deficiency. Now, there are some medicines that are out there that can cause folate deficiency. Not just they may be taking it in, but it just maybe the med that they're on doesn't let them absorb it. So The AAP and other organizations recommend it's really important for women who are trying to get pregnant to take 4 milligrams per day of folate prior to conceiving, at least through the first, and then at least through the first trimester. Alpha fetoprotein, or AFP, is usually checked at 16 to 20 weeks gestation. Some mothers do it, some don't still, which I find very interesting. This is the definition. It's defined of the protrusion of the spinal cord and the nerve roots and the 3 layers of the membrane through the outer layer. And of course, spina bifida occulta is the definition of that. Is sometimes it fails to close, but there's no herniation of the cord or meninges. Yeah, and this actually goes with basically before. So if they've got a Chiari-2 malformation and they've got myelomeningocele, you can almost guarantee that they're going to have a VP shunt because of hydrocephalus, because nothing in the vertebral column is working like it's supposed to, pretty much. All right, we're going to move on to neurofibromatosis. This is a genetic disorder. Now, here are your characteristics. These are the things you look for. One of the biggest things that we are taught as peds NPs is you need to look at how many cafe au lait spots or macules that they have that are greater than 5 millimeters in diameter. I had a baby today that had 6 different cafe au lait macules, but some of them were just tiny, tiny. Only 2 of them would have been considered 5 millimeters or greater. So that's one of the things I'm looking for. And I will see, if I see a hyperpigmented spot, I'll say, do they have any more of these? Because most parents have looked their baby over. They know exactly what's going on with their baby. So if they do, we check them out. So if they have any neurofibromas, any freckling in the axillary or the inguinal regions, that's significant for neurofibromatosis. Optic gliomas, any Lish nodules, those are iris keratomas, or if they have any kind of distinctive osseous lesion, sphenoid dysplasia or tibial pseudoarthrosis. And those are significant kinds of things. I guess one of the most deciding factors is, do they have a first degree relative with neurofibromatosis? Now, some of the things that can go along with that are skeletal deformities, cardiovascular abnormalities, neurocognitive deficits. And that's what I'm looking for, or am I looking for if I've got a kid with this, I'm looking for neurocognitive deficits. They're going to have some, not only pigmentary abnormalities, which we've already talked about, the potential for brainstem gliomas and optical gliomas and sheath tumors. These kids, if you suspect a kid to have neurofibromatosis, yeah, then you need to get them to a neurologist for further workup. Now, your job is going to be to monitor and coordinate any needed services locally for these kids, but you've got to be able to see it. Okay, so some of the things we didn't cover in this chapter today are listed here. Bell's palsy, you've probably had in an adult class. Rice syndrome, we don't see much anymore. It's usually a response to aspirin in a viral, from a viral illness. But we don't give, what did I do? We don't give aspirin anymore in kids. It's very specific, unless they're have issues with juvenile rheumatoid arthritis, and then they are managed by a whatchamacallit. Yeah, pediatric rheumatologist. Okay. All right. Any questions on that long chapter? All right, I'm going to take it 2 seconds and get a drink and rest my voice for about 15, and then we'll be right back.
Do you want me to do some?
Oh, you want to do some of your, she's going to do some of her announcements. That's what I was singing earlier. That's an old Boy Scout thing. Sorry. You want here?
Just give me the computer.
Oh, here. Let me get up
and
and move. No, I got to rest my voice for a minute.
All right, everybody. So some reminders. Let's see, the last test, we're moving that up because of the end of the semester. I don't have the syllabus here in front of me, but I believe I put on there that it opens on the 23rd and goes through the 26th. I'm going to extend that out to the 28th at 8 a.m. Okay, that should give you at least an extra day and a half or 2 days to complete that. And I will put all this on as an announcement in Blackboard as well. Reminder, several of you have turned in your community program assessment papers. Those are due Monday by midnight. I'm combining 547 and with our class today as well. For those that, just reminders for everyone still needs 3 PCAMs, or, we need 3 PCAMs for the course. Don't forget your mid-evaluation and your final evaluation by your preceptor to be uploaded. If something happens and you don't have your hours completed by the end of the semester, and that is likely going to be through that Saturday, which I believe is May the 1st, then, or I'll probably go through, if you're not done by that weekend, then I'll give you an incomplete. It's not a big deal. Then that'll give you the time to complete the necessary requirements for the course, and Dr. Main or I, whoever is your clinical person, will be reaching out to you. And if we're missing any documents, we'll be sure and let you know, but be sure and upload those documents. Don't forget to do an evaluation of your preceptor. That's very valuable information. I'm hopeful that all of your preceptors you are giving, positive marks to, but I did have one student one time that gave a very honest assessment of their preceptor, and based on, it wasn't someone not in Kentucky, but someone that wasn't supportive of nurse practitioner practice. And that was very helpful information, because that was not a place that students needed to be in. So that's important information. Competencies, everyone is required to complete competencies, at the end of the semester. So be working on those. Preceptors for next year, you're either going to be in 548 next year in the fall or 554. Now is the time to be working on getting your preceptors, especially for pediatric preceptors. If you're in 554, if you're in with a preceptor right now that you are really enjoying, it's never too soon to try to secure your site for when you do get to 554. If you have any questions about that, let me know. But, always talking with people and saying, hey, I'm interested, can I get on your books, is never a bad thing, so that you're able to plan and they're able to plan as well. I'm not for sure if you saw it in the chat section. I put in the migraine. I said that I put the migraine link in Blackboard, and so that is there under the particular chapter. And Elizabeth was talking about the KHSAA documents, and those are not in this week's information, but they're in next week's, where there is sports physical and exam information, and those things have been, PDFs have been put into there. I've put in for the form for high schoolers, form for middle schoolers. There is one, the form on return to play, and currently that can only be signed by MDs or DOs. Is that correct, Elizabeth? Nothing has changed with that.
No, but I still fill it out.
Uh,
And my doc
Elizabeth fills it out and her doctor signs it. So it depends on what relationship you have. But if someone hands that to you and says, oh, can you complete this so my child can go back to sports, know that that's not within our scope of practice. And then I also included what the concussion protocol is for KHSAA. Just for your information, it's just a document. So I think for right now, that's all the announcements that I have. And do you want to give them just a few more minutes? Or are you ready to talk?
I'm ready to go.
Okay, giving you back to Elizabeth. Thank you.